Hello, everyone. Thank you so much for joining our webinar today. Bianca, would you mind just pulling up the slides really quick so everyone can see? Next one. Beautiful. All right. Yeah, we're going to start the webinar in just one moment. Overcoming potential barriers to remote patient monitoring implementation. I'll just take a single minute to just remind you all that what's the best part about our webinars is that we get to hear from you. So as we are talking, as we're discussing, make sure you put your comments in the comment box, but your Q&A and questions, put those in the Q&A box so that I can make sure I can see them as we're going. Yeah, so after we have our discussion, we're going to do a few Q&As from myself, and then we want to hear from you guys. So make sure you put them in as we go. All right, I think we're getting up there. So usually we like to do this thing where I want to hear where everybody is coming from. I want to hear where you're joining from. Sometimes we get people all the way from New Zealand. I like to hear if anybody's from New Hampshire, because I grew up on the seacoast of New Hampshire, so I like to bring it home. Beth, Colin, where are you guys calling from?
Hey, how are you? Beth Friedman, calling in from Northwell Health. And at the moment, though, in Passaic, New Jersey.
And Colin Waring, and I'm calling in from Detroit City, Michigan.
All right. And I'm calling in from beautiful Arlington, Virginia. I just want to make sure can everybody see the chat? Sometimes we're having a little issues. So if you can't, somehow tell me. All right, we got one from Alabama. We're good. All right. So I will get us started today. Thank you all again for joining us today. Bianca, would you mind going to the next slide? So we are the Executives for Health Innovation. We are a nonprofit based out of Washington, D.C. We convene executives from all across the healthcare industry. And what makes our group so great is that we're able to bring these people that have all of these different views and these experiences and these opinions together. And we're able to look at the issue area from all different angles. And I think this allows for more meaningful and thoughtful solutions. So next slide. So we do that through collaborative learning, which is webinars and briefings. We shape policy through educational meetings and briefings. We used to be on the Hill. We'd hope that we can do more in-person briefings soon. And then through thought leadership, which is our roundtables, which are usually 18 executives that would come into the room together. And our focus areas currently are patient experience, health equity and access, digital care, and privacy and cybersecurity. That's not to say we don't do other work, but these are our main focus right now. And I do think that they show up in a whole lot of issue areas. So you'll see that as if you look through our webinars as well, we do that. Next slide. And we are a membership organization. So without all of these wonderful members, we wouldn't be able to do all of this great work. If you see your company on there, know that you're also a member. So if you want to join us, if you want to hang out, if you want to get involved, you can just put something in the chat and I would be happy to get involved. But if you don't see your organization there and you want to get involved, you can also put that in the chat and I will also help you get involved. Yeah. And we've been doing this for a long time. You can see that while the focus areas have slightly changed, EHI has always been focusing on working towards a consumer-centered health that is low cost, high quality, and accessible for everyone. So while it changes, EHI is always there. Next slide. And examples of some collaborative learning. Tomorrow, we actually have a short policy briefing with some of our members of the Policy Steering Committee. And we're going to go over what the November 8 election results will mean for health IT policy. Again, it's very interactive. So if you have some questions that you want to hear from our policy steering members, you can go on our website, ehidc.org, and you can sign up for that. And then we also have past events that you can go and see in our resource center. And of course, again, Without our fantastic membership, we wouldn't be able to do all of this great work. So I want to thank Redox today. And also, we have Northwell is also a member. So we are really member strong today, but I really want to thank Redox today as well to help us bring this information to you guys. Yeah, all right. And so I want to introduce Beth Friedman. She is the AVP for Clinical Informatics at Northwell Health, and Colin Waring, Senior Product Manager at Redox. So Beth, I think you're going to be the one to start. But while we are getting ready, I just remind you again that we want to hear from you. So as we're going, feel free to put that in the Q&A and we'll hear those. Thanks, Beth.
Thank you. Excited to be here and hopefully have a great conversation with everybody. Thank you, Emma, and the rest of the team for helping us to be part of today's presentation. As they mentioned, my name is Beth Friedman. I have been working at Northwell now for coming up on 15 years. My background is both in pediatric nursing, I've taught nursing, neonatal ICU, and then also I'm trained at Columbia for biomedical informatics. My roles at Northwell have spanned from analytics and interoperability and health information exchange to leading teams to develop applications that are currently in use in care management and other ambulatory settings, as well as, and this takes us to where we are now, really over the last 3 years, my focus has been on exploring new and novel technologies having to do with sensors and remote patient monitoring, remote physiologic monitoring across the continuum of care. Next slide, please. Our goal when we began this journey actually defined RPM perhaps a little bit differently than the way some of you might expect, in as much as we are looking at opportunities to use all sorts of sensors and IoT across the continuum of care. And so, as you can well imagine, during COVID, this became very important when we had such high census, trying to figure out how we were going to monitor our patients in a safe way. At the same time, safety of the patient, safety of the provider. And even during this very difficult time, our primary start was really to explore devices in the inpatient setting. So these were, continuous pulse ox and patches where we could monitor our patients remotely, identify patients who are at risk of deterioration. So our vision for RPM spans that environment, pretty much exclusive of the ICU and telemetry, but the rest all the way through into ambulatory care, hospital at home, and so forth. And so based on those experiences, which I'll share with you, we came up sort of with a vision and mission statement with a very strong focus on personalized and precise care for our patients. I'll discuss a little bit not only the devices and the service that we provide to our patients, but our interest in the data and how we use it, with a mission to really roll this out at an enterprise level. A lot of the work that I'm going to share with you today was really more pilots that we would run on a particular unit or with a particular cohort of patients. And we think that at this point, we've gathered enough information to actually begin to start to plan what an RPM capability would be at Northwell that scales easily for both of our patients throughout the community, as well as our providers. Actually, what I've neglected to share with you about Northwell, for those of you who don't know, we're 23 hospitals, hundreds of practices. Our centers are tertiary centers and community centers as well. And we have among the most diverse patient populations in the United States because we service both more rural communities and have a very large patient population in New York City as well. Next slide, please. So expanding on that theme of our definition of RPM, we're really trying to figure out and have spent a lot of time thinking about what does it mean to have an enterprise patient monitoring capability at Northwell. And so all of these different topical areas that you see here are really our attempt to recognize that this is a multifaceted new set of technologies that we really need to deeply explore and understand. So for sensors, what is the world of all of the different kinds of devices? We all know about fitness trackers, and probably many here are familiar with a lot of the medical grade devices. But we're also talking to vendors who are looking at smart homes and working on contact-free technologies that allow our patients to be able to freely move around the home or even within the hospital room, and us to be able to collect that data. We're also very focused on what is the platform that one needs to be able to do RPM. And that falls into a few separate pieces. There's the part where you have a dashboard and where you're monitoring a patient for trends. But because our goal is to get to the point where we leverage all of the data that we're collecting, be able to build algorithms and to actually be able to predict risk, for us, it's very important to have a platform that allows us to aggregate all of the data that we're getting from all of these devices. And I want to emphasize that there are the devices that are here today, and there's the vision for being able to move along with the technology and advance forward with the technology and be able to integrate those devices as well. This has been kind of essential for us. I think the other part of this that is the challenge, unless we can come up with this solution, is that there are many different devices, each of which has their own app, if you will. Whether on the inpatient or the ambulatory side. Glucose monitoring has an app and they send summary data into the EMR. There are blood pressure cuffs that have their own app, or there are companies that have a small formulary of a handful of devices, and then they have an app that wraps around those, but they don't have any integration or room for growth beyond that. So that's something that Northwell has actually spent a lot of time with. Similarly, for the business models, we have explored what is the cost-benefit ratio on the inpatient side, understanding that when we use disposables to monitor patients, that there's a cost associated with that, and trying to understand which are the target patient groups that make that benefit worthwhile. And same thing on the ambulatory side. There are different kinds of business models, as you all well know, whether there's vendors that we farm it out completely with, whether there are vendors who are willing to collaborate with us, both on the data science and on building out a business model together. There are business models where the care managers are part of the vendor offering, but Northwell has a very significant care management capability within our own organization. And I would argue that this is something that we spend a lot of time right now sort of trying to figure out and to sort of map out in the next year. I've mentioned the data science piece of this a little bit. We have data scientists who are very involved in the projects that we are launching. Every data project that we launch, we collect all of the data, we store it at the back end. We have our data scientists analyze it, validate it, and so forth, and that's ongoing. And then finally, there's the communication piece, which is not, this involves the alerting. How do you visualize data? Who's looking at it? What do the physicians really want to see? And what is data overload? All of those pieces have really made up what is our RPM strategy. Next slide, please. And so just quickly, I want to tell you a little bit more in detail about the work that we're doing, but I think we're excited for these challenges and opportunities. We see this as being as a challenge because now we're monitoring patients in their own space, in the place that is most convenient for them. So we're monitoring them in the home. They're more active. They may not be at rest when they're taking their vital signs or when we're collecting them if we have devices that are continuous. And so we need to understand how to interpret the data that we are receiving and how to filter out the noise in what we call free living conditions. That's not trivial. And in fact, part of the exciting part for us is to really understand that relationship between activity and vital signs. If you imagine in the inpatient space, you go into, Mrs. Jones's room, she's making her way back to the chair so that you can take her vital signs, but ultimately that's at rest. All of these new technologies around the smart home or around, continuous monitoring and fitness trackers, those are not patients at rest. And we need to understand, how do we interpret that? What are the appropriate alerts and thresholds that we need to use in the short term and ultimately replace them with a long-term strategy around predictive capabilities. We've spent a lot of time in the examples I will share with you around feasibility of the model, feasibility of the technology model, but also the usability from the patient standpoint. We survey our patients to understand whether or not they are comfortable with the devices that we're sending into the home. Does it make them feel more protected, which some of them say that it does, or does it make them more anxious? And which are the ideal populations for us to be using certain technologies, and in other instances, when is it overkill, or when is less frequency appropriate? Another word just about the clinician workflows. You know, in analytics, we talk a lot about a data lake. And in our informatics team, people tend to joke around that we've gotten to the point where our clinicians say that they're drowning in the data lake that we've created with them and all the data that we present to them. So again, very, very important for us to understand the workflows in terms of monitoring and learning and communication with the provider. Because one thing that they've made crystal clear to us is that while they are very much in favor of us doing RPM, and they understand the value and the benefit, and we've spoken to many of them and surveyed them formally, the burden that would fall onto their practice is something that we have to account for, and that the workflows that we build in order for them to subscribe to it have to be easy to use and minimize the burden on, and allow them to be able to see their patients uninterrupted. So that's it for my slides, but I do want to start to tell you a little bit more about some of the projects that we've done. On the inpatient side, again, we have used pulse ox and monitoring vital signs, heart rate, respiratory rate, activity, non-invasive blood pressure. We are just actually expanding, and ECG, just actually expanding some of our work, and particularly one of our tertiaries, to 3 or 4 different units. We monitor all of the impact on RRTs, rapid response events, and on transfers to the ICU. We might not prevent that transfer, but we can certainly maybe intervene so that the patient is in a less deteriorated state when they get there. So those are projects that we're actually very excited about. As I say, we've I think at this point monitored more than 2,000 patients, and all of that data collected, from the various vendors. We've spent a lot of time thinking, comparing the data to our EMR, because building trust amongst our providers, very important for us to be able to use these devices. We've mapped out our EMR, and even in the cardiothoracic ICU, against the data that we get from the different devices. And we've used our medical leadership. All of our projects involve a participation and a collaboration across nursing, medical informatics, and the medical executive medical leadership. So that speaks to the inpatient side. For the ambulatory side, we've worked very closely with our care management team, in particular around transitional care management. We've had resources go into the home, help patients get set up when we were doing continuous monitoring. We work very closely with our vendors who are providing some of the tech support to make sure that the data is flowing well. We want our providers to practice at the top of their license, and we don't want them spending time on tech support. So we work very closely with our vendors to make that process a little bit smoother. We've also experimented with when we provide devices to patients in the post-acute space, meaning the patient is discharged. We're kicking off a pilot now in pulmonary medicine to be able to patch certain patients at the point at which they leave, so we don't lose that important time where they're at risk of readmission. We've done, as I say, other versions where we go into the home and where we patch them. So very different. And we've had other instances where we've tried to do it with virtual support. Pros and cons to each, both from a financial standpoint as well as patient satisfaction. We've also done pilots that we've kicked off around patient anxiety and looking at sleep. This is not billable under the routine CPT codes that we generally speak about, but it does fall under 99091. And therefore, our ability to experiment with some of the technologies that are maybe a little more novel fall under that coding as well. Right now, up to now, we've not really so much been actively billing. We spent a lot of time with our legal, figuring out the compliance and the consents, and working with our vendors to figure out all of those pieces. And that's why, as I say, I think we're just about at the point now where we've got all those pieces cobbled together, and we have some champions in the medical practices, so that we really can be able to launch this and get a deeper understanding of what does it take to maintain this kind of monitoring over periods of months, and what does the business look like for both provider documentation and ultimately for reimbursement to our health system. I think that kind of I think summarizes a lot of the work that we're doing right now, but looking forward to discussion and answering some questions.
All right. Thank you so much, Beth. We have a whole lot of questions for you already, and we will, and Colin, you are up. Make sure you send your questions for Colin as well as we keep going.
Good afternoon, Colin Waring. I wanted to pivot off of a couple of the comments that Beth made. Great presentation, by the way. I really like the way that you laid out the focus areas. And I wanted to draw a focus to the difference between looking at data, understanding how it was collected, and being able to interpret it properly, and the effort that you've been spending on the platforms and the technology to connect to and acquire the data, and the effort that it takes to isolate the patient or to optimize the patient experience and the clinician experience during that process. And bring really in that Redox is a provider of what we call component, which serves those three main areas. It's a technology enabler for the communication of data and the creation of convenient and optimal workflows, the patient experience side and the clinician experience side. So what we're seeing in the market is, as you might have inferred from Beth's presentation, a wide variety of an increasingly diverse population of RPM vendors, each with a separate app, I think was the jargon that Beth used, or individual platforms, and all that have a somewhat unique patient experience that they quite rightly have optimized for. What we also see then is the challenges that a provider system such as Beth's would face in attempting to connect to and harmonize across all those different providers, all those different RPM vendors, bring that data in and isolate the people within the clinical set from that variation and the technology issues. I think she was commenting that she wanted people to practice at the top of their license, not be burdened with the inevitable overhead that comes with trying to debug platforms. So Redox is a solution for that technology line item, that interoperability and workflow enablement, with a focus on a flexible platform that supports concurrently the independence of the RPM vendor to offer a unique and compelling patient experience, and allows the provider to simplify it and yet retain the level of flexibility necessary to address variability across the different types of RPM classes and RPM vendors. So with that, I will open up my sales slides. Give me a moment, I'll share my screen. Redox is a platform that allows interoperability between a wide range of digital health solutions and healthcare organizations. On this slide, you'll see that Accelerate RPM Strategies is just one of the many solutions that Redox offers, but it is the one that we're focusing on today. The interesting part is that many times the connecting to and the interoperability with the RPM vendor is just one aspect of the clinical workflow. And we'll touch on that a bit later. So it's very helpful to have the competencies across all these different steps in the process. Fortunately, one of the individuals that was slated to participate in this discussion came up sick. He was unfortunately illness. And that individual was a partner with us at Memorial Care, who was very interested in reducing the amount of effort and time that they were spending collaborating with, designing interoperability solutions for, and shaking out the connectivity and workflows associated with bringing them inside or onto a clinical workflow or acceptable workflow for the business. So they partnered with Redox in order to allow this plug and play or a more standardization, a simplified version of the interoperability process, but also to allow the flexibility to address the inevitable differences that occur. So this idea of standardization and flexibility as competing objectives brings us to the concept of composable healthcare. Composable healthcare, what you're looking at here is a classical business management workflow slide. We have the top level, which is the provider. The second layer down is the platform. The third layer down is that RPM application. And the bottom layer is the patient experience. So this workflow indicates that the provider experience can be ordering the patient monitoring device. Time passes, and in the next encounter, they review the patient record. And in that record are the appropriate level of detail for the data they need. It could be a PDF of a report. It could be particular vitals or observations in a flow sheet, or it could be, as Beth alluded to, a more detailed view into a data lake, ideally more structured data that allows you to trend over time and those type of things. And each encounter and each provider may want access to a different level of information. The important part is that with the single platform, you can compose interoperability that supports all of these workflows. The last step on the far right-hand side shows what is referred to as Smart on Fire launch, and that enables us context-specific invocation of the supplier's app. So it means that if you really like to look at the Abbott CGM monitoring software, well, you just fire it off from inside the EHR system. You can view the app, and you're restricted in a secure way to just view that. So that's augmenting the clinician experience. Often that's more of an advanced. The last point is made by these slides is that because Redox has connectivity to many health systems and many device manufacturers, you're getting a leg up on scale. By that, I mean, you can integrate, we have subject matter expertise and a focus on integrating with and transmitting the information between and supporting the workflow of these vendors. And that gives a starting for simplifying and scaling the rollout of these solutions within any given provider organization. So in summary, what I'm trying to convey is that the challenge that Redox sees in the market is the proliferation of RPM vendors, each with a slight variation in their solution, which can be a bit overwhelming if you try to address it without a partner. What Redox provides is a partner technology and subject matter expertise that allows you to jumpstart this process, reduce the amount of effort and focus you place on the technology platform, and allow you to focus on making sure the data is good, you understand it, that the patient experience is well crafted, and that you have a efficient and effective clinician experience for your business. And we would offer partnership services. Again, you can visit our website. I'll drop some links. But in summary, I'll just repeat one more time that REOS is a provider of the platform and services that allow providers such as yourselves to reduce the level of effort and need to deal with the complexities involved with the technology platforms, and provides a toolkit, composable healthcare, that allows you to more easily engineer a patient experience and a clinician experience that meets your needs, period. So I appreciate your time, and I look forward to an interesting discussion. Hopefully this was a helpful intro.
That was great. Thank you so much. And also, let's hopefully get Beth and Colin back. We can start our Q&A. Perfect. All right. So everyone out in the audience, I have a few questions that I pulled together based on some of the questions that you guys sent in during registration, but definitely keep putting them into the Q&A box. Everybody's started already, and so this is great. So I had this, so once, so everybody, once they start, thinking about it, developing, implementing these programs at their organizations, what do you think are the key points that they should talk to their leadership about that really help them understand the ROI of these solutions? Like, make sure you talk 1, 2, 3, or whatever.
So I think maybe I would, I'll take the first shot at this, Colin. I think I would focus a lot on scale. My experience really is when we look at this, when we look at the literature, even on the different trends for a lot of the different chronic disease management programs, they talk about small programs, and they talk about individualized programs. And especially at Northwell, we have many different kinds of practices. Their workflows differ to some degree. Northwell was grown by acquisition, so there are certain practices who were accustomed to doing certain things a certain way before we brought them into the mix. So I think understanding what does it take to make this an enterprise project and to offer these services at scale is something that we've looked to our leadership to help us out with. And also taking, I think, into account what does it really take to roll out such a program in terms of staff support, both from a staff education standpoint. How do we educate all of our physicians on why this is worthwhile for them to do? Clinically, they might agree that this is worthwhile to do, but how do we educate them on how they can do this in a way that will not be too burdensome to them? I think those are the two top ones. In terms of the third, I think just
You two's great. Yeah, I appreciate it. No, those are fantastic. Those are fantastic. What about you, Colin?
I guess my analysis would be a bit more first principles. I would look at the revenue and the cost side. So in order to be able to, and again, it depends on whether you're more value-based care or whether you're doing fee for service. But in terms of the coding and the billing, I think you have to make sure that the information from your remote devices is available in the context that allows for the use of that information in an encounter so that you can justify the use and invoice through in a truthful and practical way. Then on the cost side, I think what Beth was saying about the providing at scale is a key point, especially when you set it and when you juxtapose it with her other point that there's a devices, there's a certain amount of variation in the workflow that the individual clinical settings might require. And therefore, you're struck with this kind of exponentially increasing complexity that is necessary to manage and control if you're going to maintain a decent control on your costs. So this is really the, again, pivoting back, I'm really almost like you'll keep hearing me return to this theme because it is offering. It's this idea that there's a way to balance those two effectively with the reform. And our focus is to allow that variability to exist. Don't try to force all of the vendors to behave in the same way, except that they're going to behave differently, and offer enough flexibility in the technology platform and the way that they compose their workflow so that they can have that autonomy and that same guiding principle to the clinical setting, where if you have people that are dealing with the blood pressure information, they may want a different level of detail, or they may want to have a different than maybe a continuous glucose monitoring or something similar. And each one of these are unique, and you don't want to get caught up in too much time. You want to really have something that you can almost pick off the shelf and provide to them. And I think, Beth, in your environment, you spent a lot of time kind of assessing the landscape and getting a good feel on what that scope is. And I'm very interested to hear your thoughts on how you turn that into actionable item for out at scale, because key point at the beginning of this was that idea it needs to be an enterprise that has both a cost side and a revenue side.
I think you've made some outstanding points. I don't focus on the revenue piece, which I think is because I think there are other people on my team who are always telling me that I have to think about that, and I'm more clinical in my thinking in some ways, but I cannot emphasize enough or tell the group how many hours we've spent on 4 CPT codes. There's a certain complexity to that I think, to your point, offloading that complexity from our providers and scale, the same thing to what you mentioned, offloading the need for them to evaluate different devices and figure out how all of them come together so that they can provide the necessary care for our patients. I think reducing complexity is the theme that I hear you talking about, and I 100% agree that in every aspect and in all the feedback that we're getting, whether it's from our billing department, rev cycle, our providers, it's all around not having lots of choices and having much of this sort of planned for so that they can focus on the part of their job that they want to do, which is providing patient care.
Right.
This is a really great discussion. So take these ideas and now they have a fantastic program. It's great. How do they create a sustainable program? How can they make sure that it continues to be great and continues to work?
Well, Beth, if you want to pass the baton,
Yep.
I think I feel that is just an extension of the ROI principle. I mean, we talked about being able to manage complexity, and that's also the same challenge that you have as you begin to sustain the program. So if you find that an initiative has a larger cost as you begin to add more people to it, more participants, and as Beth was saying, the complexity lives in a number of different areas. It lives in the billing, it lives in the experience, it lives in the technology footprint. Our advice is that if you're going to be sustainable, you probably need to partner with your RCM team, with your technology providers. And what we're suggesting, again, this is a little bit of a self point, but I think if you focus on the clinical experience and the business of a hospital, you probably are looking for a partner that can help you reduce the amount of effort and long-term support that you put into the software and interoperability side. Like, I've been working in software for decades, and the sad about of the cost of software is in that long-term support and sustainability. And with the difficulty of retaining people and the turnover that you see, that becomes a real challenge for the IT department organizations, which are often kind of overwhelmed by the whole volume and complexity of their asks. Beth, again, that's my perspective from that narrow focus.
Yeah, I would say that you've nailed it. You know, I remember a long time ago in a business course that I was taking, they would tell us about how organizations, when they were small, they would hire outside vendors in order to help them. Then they got a little bit bigger, and so they thought that they would be saving money by bringing things in-house. Then there was a point where they got even bigger, and they outsourced it again. So because that was not their core business. And I think that that's what I'm learning as we have all of these discussions across the finance teams and the clinical teams, is that Northwell has a particular objective in what we're trying to do. I think there was a question in the chat of whether we were planning to build or buy. And I think the answer to that question is that I've been given very strict instructions, and I'm the one who leads some of the development teams, that when there's an opportunity to buy, we have no intention of building, for the very reason that you say, which is in order for something to be sustainable, we need to be able to collaborate and rely on partners who are going to offload some of the parts of what it takes to make this successful, so that we can focus on the part that we are hugely good at, which is the clinical part.
Awesome. I'm looking at the questions coming in, and quite a few of them actually have to do with the question I was about to ask, so I might as well bring it in. How do you see RPM's potential with low income and other vulnerable populations? We're talking about scaling. What kind of advice do you have for those people?
Beth, I'll pass that one to you.
So I think that's an interesting challenge for a lot of reasons. And Northwell has actually, over this past year in particular, spent a lot of time exploring what are the challenges for our different populations, and how do we come up with community solutions for them. I think the way we're trying to imagine our RPM is that it's not that we have to, like with any business, be able to support sort of a few different methods, if you will, for how we connect with our customers. And in some instances, it'll be through RPM and in standard ways. And in other instances, we'll be reaching out to the communities and working with libraries and churches and all of that, and figuring out what those kinds of, workflow, what kind of those business models are as well, in order to be able to monitor our patients. It gets complicated sometimes because Medicaid does not support the CPT codes in the incident too. And so figuring out how do we, in some instances, we're obviously not going to select certain populations and not others. So we're looking at financial models that allow us to leverage whatever billing codes allow us to support all of our populations, and sort of have a blend of the different kinds of services we provide, and at the same time being able to support all of our different constituents.
Yeah.
Awesome.
What I would offer, Beth, is that as a sort of technology and platform and partner, it's important to keep it simple. Any barriers you put up become increasingly prominent as you get into sort of less advanced. And that includes language barriers, complexity, access to technology. So all of these things are very difficult to overcome, especially when you're dealing with a remote patient monitoring device, which tends to be tech to begin with. So I guess that would be my one observation, is that some of the vectors we've been pursuing are simplicity.
I want to build on that. Actually, when I first started to explore this space a few years ago, I remember sitting with our health home team. So that's a Medicaid population. And I was showing them all of these technologies that I just thought were the coolest thing since sliced bread. And only to find them, the response was, these things are great. We were talking at the time, it was a behavioral health use case. These things are great. But Beth, you have to start out, with the recognition that some of these people are not necessarily even living at home. And so how do we actually reach them? And if you think you're going to give them a wearable device or a watch, or it's just not feasible, let alone sort of what is the wireless, capabilities that our patients have, or do we have to do it via cellular? We have lots of conversations actually with, some of the big wireless providers for that reason, And some of our conversations, even with the vendors, the product vendors, does your data go through cellular? Does that cut out a population if you don't do that? We require that our patients have wireless, and who's going to pay for those, that capability? So it's a very complicated topic, I think, on many levels. Again, across all the pieces, the workflow, the right device at the right time, and personalizing, what we give to our patients so that it's most suitable for them.
Yeah, and so I'm looking at another one here, and so going back to that conversation of listening to the patients, what they actually want, what they actually need that maybe you didn't see the first time. What are you seeing with having patient engagement or buy-in, or if there's any key factors in these programs that really help patients get involved and participate and keep participating?
I'm going to harp on the right device for the right patient theme. And I think that we have certain patients that we're able to do continuous monitoring and they do fine and they love it. We have others where it's just not the right choice and the right device for them. So I think that, and if you find yourself, I'll give an example from the tech support side. What we found is that we were reaching out to the patient. The vendor who was supporting us on the logistics side was calling the patient to find out why their data maybe wasn't flowing. And then you find the patient just getting this barrage of phone calls that was totally unintended, but everybody's sort of doing sort of their little piece of the pie. So, maybe it's just finding the right device, and maybe blood pressure once a day, or as I mentioned, cellular. They're looking for the easiest, simplest way to be able to communicate their data. They don't have a problem. I find actually the easiest ones are when we do blood pressure and scale. That data seems to come in on a daily basis without very much effort. The moment that we get into something more complicated, there are all sorts of complications, and that's sort of a trade-off, that we have to figure out. Is it what is the clinical benefit that we get versus the effort that it takes in order to deploy those technologies? We talk about that a lot.
I would plus one on that. It's if you think about your own experience, accessing healthcare can be frustrating, and it's rife with hurdles and billing engagements and approvals from insurance companies. So if you can make that engagement process simple and provide the patient an experience that they know gives them value, both between the encounter as well as see concretely that the information from their participation is being used by and is helpful to their outcomes. I think that would be a motivating experience, and that conversely, anytime you put barriers in the way, extra things you have to do, phone calls you have to take, debugging you have to do your network, all those things make it more long-term satisfaction. It's pretty much stating the obvious, but that's I think people are people. That's just the way it is.
And so thinking about all of this fantastic technology, how would providers have a data overload problem? So how do you address any burdens that this might put on providers' workflow, already heavy workflow? Or do you have any instances that you've already worked through that you might have to share?
So I think in the transitional care management space, again, going back to more of the continuous data, we've spent a lot of time sort of thinking about what kind of data and with what frequency do we monitor that data? Are we using? I often say if our patients needed 24/7 real continuous monitoring, then they belong in the ICU and not at home. And so, figuring out, to your point, what is the right technology that we use, and how do we now? That's why I talk so much about the data science. How do we now take that data and boil it down to something that is actionable, rather than just endless trends where they just have to scroll and scroll and scroll to understand what's happening with the patient, let alone try to look across 2 different biomarkers. So I think our experience is in that we've sort of experimented a little bit with what is the frequency, even the practices. I mean, there are some amazing things that were done during COVID by some of our practices, where they were sort of monitoring patients morning, noon, and night, and that is not at all an exaggeration. I really don't know how they did it. But they also realized that, getting back to the scale question, and now that they've come back to me and said, Beth, we did this with COVID, we want to start talking about some other cohorts. They've also recognized that that was not sustainable, and that they have to figure out a way that the frequency with which they monitor their patients is livable. So I think that's practical for them. How often does their practice actually work directly? We have a few models. We have the care management model, where the care managers are interacting with the patients more, and then there were the models where the providers were directly interacting with their patients more. So finding a balance, I guess, based on acuity, we don't have the answer yet, but we're definitely exploring several models.
I think that's a great way of saying that you need to have a choice, that the same level of detail and granularity of data and frequency of collection doesn't work in all cases. And there must be flexibility as to how that data is collected and presented within the clinical workflow. And our approach to that is to provide those as choices, so that you can have a report that goes in as a note. You can have structured data that goes into the record. You can have data that flows into the data lake, and that at least that choice of what granularity of data is available to you, as we were talking about, Beth, without a lot of complexity and decision. It's just one of the options that you would pick as a practice when you were deciding. And then in the future, for that sustainability discussion that we were having, if you elect for some patients, or if you elect in the future to take a more detailed look, well, then that option should be available to you as well, to add to your workflow in that particular case. And our view is that you don't want to make that a science project. You don't want to make it a big IT integration. You want to make it, oh yeah, okay, we'll turn that on. You can have that tomorrow. And that's the way it should be for both the patients and the clinicians. So I'm not sure if that was a helpful contribution, but choice is important, I think. And you must support them all. The question is, what context for which level of detail is the challenge.
Awesome. This conversation is great. And we are getting so many questions right now. And so I know we only have 8 minutes left. And so I want to try and get a few more. And so one of the questions that I was going to ask, and that I see in the Q&A, is there a particular population that you've seen with RPM being most successful? In some that maybe the populations that it's not as easy to get retention.
I don't know that I would that we're at that point yet, because we've kind of looked at some of the cohorts, the usual cohorts that people focus on, hypertensives and congestive heart failure and that sort of thing. The literature interestingly suggests that in certain instances, you would think that younger populations, more familiarity with technology, would be ideal. There's some suggestion that the older populations are, I think, a little more patient in consistently using the technology. I'm going to take this in a slightly different direction and say that everybody does a great job in month 1. The question is, what's the drop off? And what is sort of that sweet spot for us for how long we would want to monitor a patient in a way, obviously, that was justifiable from a billing standpoint. But people get a little tired after a while of taking their blood pressure every single day and that sort of thing. So I don't know that we've quite nailed down the patient yet, but I think that we recognize that we're going to have to figure out how do we make it easier for patients to comply.
Yeah, there's that easy to comply concept again. We've seen pretty good uptake with again, we're a partner to the RPM vendors and the providers. The diabetic population seems to be a pretty good market. There's plenty of devices available. Many people buy them and use them themselves. And there's a benefit to having that information available within the clinical setting. And I know Abbott and Dexcom are two of the people that we've worked with. And then Omron also is a vendor that provides more of that blood pressure. And there's a few others that we have. I dropped some links earlier, but there's a number of vendors that we've integrated with. And what that implies is that they are actively sharing data back to health systems. And so, Jess is on the line, and I think there's probably some good information that you could get from our business that I don't know, if you're interested in those kind of questions.
And so just quickly, I know this came up earlier. So Beth, you were saying that you guys are currently not billing for the RPM services, but what kind of challenges do you expect to see? I know this is probably one that could have its own webinar. So, but just quickly, I know I saw it a few times. I just wanted to ask really quick.
So I had this conversation literally just before we began this call. Again, with people who are, I think, more sensitive to the challenges of billing. And so I think at the end of the day, getting people to cooperate and document, we're asking our providers to request the service. We're asking our providers to circle back at the end of the month and review whether it's, a lot of data or a report, and then drop a note in order to have the billing go through. I think from a financial standpoint, I'm the optimist, and there are others who are trying to temper my optimism and not assuming that every single patient is going to have all the necessary documentation in a timely way. And I defer to their expertise. They've done it before with all other kinds of care management and gaps in care types of services. And, we know that our billing departments are always running after providers to document, one thing or another, or sign their notes or what have you. So I think figuring, that piece of it out, because we're so dependent because of the way the rules are for billing these CPT, we have to kind of figure that piece out.
Yeah, I would defer to Beth on that. What we see is if the information ends up in the electronic health record automatically without friction and is available in the regular course of an encounter through the provider's typical workflow, then they're far more likely to use it. And as a consequence, you can get the additional follow-up to get the invoicing. But that all falls to that very commonly recurring theme of whatever you can automate, whatever you can do in the background, do it. Keep the workflow simple and see to the degree that you can make the changes very minimal and reduce the friction, because that reduces your training, it reduces your ongoing support, it reduces a lot of the challenges introducing any new treatment. So again, Beth, I keep returning to this. I sound like a one-trick pony here, but it's that idea of simplicity and lack of friction that we keep returning to as a business.
Absolutely. I think we're finding exactly the same thing. That is the subject of many of our discussions. How do we make it easier? We're not going to succeed. We know that.
Awesome. And so with the last few minutes, I would like to ask you, I'm sure everybody's going to leave with a lot of information. I know I was taking notes. I have a lot of new information, but if someone were to leave and take away one point, what is the point you want to drive home?
Beth, I'll defer.
I think it's the excitement of believing that we believe that we can make a difference, and it's just a matter of how can we, not why can't we. And the technologies, I think, and the available partners for us to figure out how to do this are becoming more and more sophisticated and more advanced. And I think we will learn how to do this because we have to. Our patients want it. We see that with all the other commercial models that we're reading about in the news on a daily basis. I think we see ourselves, because we are a care provider, as being, the optimal partner to our patients in their care. And so I'm optimistic, I think, is what I want to leave everybody with.
Well, I would first of all say it was a pleasure speaking with you, Beth. And I think that the work you're doing at Northwell is extraordinary. I mean, the level of depth and the investment you made, very inspirational for me. So congratulations, first of all. The founders of Redox have a mission statement that is characterized by the tagline that we are all patients. So we are all patients. Everybody knows patients. And this is something that can improve the patient experience. Can improve the patient experience. It can improve the healthcare outcomes. And so it's a worthwhile goal. And I think that as a community, it's quite achievable. Not easy, perhaps, but very achievable. And I think that is the message that we live by, or the sort of inspirational message that we have within our business as well.
Awesome. And so, Beth, Colin, thank you so much for today, our conversation. Just a reminder to everybody, you can hang out with us tomorrow too. We have a November 8th election result webinar, and we would love to see you guys all there. So you can go to our website. But thank you so much.
Thank you.
Thanks for your time. Appreciate it.
Thanks.